Hello, this is Dr. Gay from First Look MRI, and this is a 52-year-old female who has had a rotator cuff repair. This is her supraspinatus tendon here. This is her supraspinatus muscle, and the muscle comes horizontally, turns into the tendon, and the tendon attaches right here on the greater tuberosity of the humerus. This is the humeral articular surface. It rotates in the glenoid here. This is the joint, and again, this is the top of the rotator cuff. We see that there are two anchors here. One is the medial anchor. This is right at the supraspinatus tendon attachment. And there's a more distal anchor here. And sutures come off this and they attach to the rotator cuff. And both these anchors look like they're well seated. And there's increased signal. Normally this will be really dark, jet black, but instead it's gray. And that is a finding we normally see after surgery. Anytime you have surgery, you'll get healing factors come in, and we call it granulation tissue that will heal, and you can see intermediate signal like this, and it's not something we worry about. We just call it post-op granulation tissue that we expect after surgery. If they had not had surgery and we saw the same signal, we'd say there's prominent tendinopathy or irritation or breakdown of the tendon, but with surgery we think this is related to granulation tissue for healing. So no full thickness re-tear of the rotator cuff. In this patient we gave some contrast into the joint. Here's a little bit of contrast that's white, and it's hard to see the contrast because the fat is really bright. It looks just like the contrast, so we do fat suppression, and with the fat suppressed images we see the contrast down here in the joint. Here's a little bit of contrast here in the joint, but we also see contrast in a place we don't want to see it. We see it outside the joint. This is the subacromial subdeltoid bursa, also up here in the AC joint. Now the patient's AC joint has been resected, so the contrast up here is just going up into this widened AC joint. And the question is, why do they have this contrast up here? Normally when we give contrast, we're worried about contrast extravasating out, and if it does extravasate it out, we look where it extravasates, and we may be able to see a small tear of the rotator cuff on this, allowing the contrast to escape. But in this patient, the rotator cuff looks intact. We do not see a re-tear, and so we have to find out, well, why is the contrast extravasating? When the patient has surgery, sometimes the trocar that goes into the joint or goes through the joint capsule can leave a small perforation or tiny little hole, and the contrast can leak out. Sometimes we don't find where it's leaking out, but we do see that it is leaking out. But as long as the rotator cuff is intact, we're not too worried, and we know that it can be normal to have contrast extravasate out through a tiny perforation that we cannot find. Now in this patient, we're going to put up a sagittal view, and we see the subscapularis part of the rotator cuff, the anterior tendon of the rotator cuff looking good. We see the supraspinatus up here. This is the tendon, and there's the muscle. Infraspinatus teres minor. As we go through this from lateral to medial, we see no full thickness re-tear. Things look very good. This is the patient's biceps tendon right here. The biceps tendon looks okay, but right above the biceps tendon there's a little defect here. This is where the contrast is extravasating outside the joint up into the subacromial subdeltoid bursa. And the biceps goes through a little channel here. We call it the rotator interval. The interval between the subscapularis in front, supraspinatus up top. There's the rotator interval where the biceps tendon goes. And the roof of that normally has a fibrous band, part of the joint capsule. And in this patient, that band is gone, and the contrast is extravasating out through that. And this can cause shoulder pain, but they don't treat it surgically. I just did a little literature search, and they said typically they treat that conservatively, so there's no need to go back in and redo the surgery, but this can be a source of continued pain following a successful repair of the rotator cuff. So in this patient, they have no full thickness re-tear of the rotator cuff, but they do have extravasation of contrast through a small tear of the rotator interval. And that's it. Thank you very much.